Good evening. I'm Dr. Paul Shupe. I'm an orthopedic sports medicine surgeon with UT Orthopedics. I'm happy to be here tonight talking about athletic injuries. My presentation's entitled Doc, I tweaked my knee. A common phrase we may hear on the sideline or in our sport of participation as an athletic trainer or as a doctor. So I'm going to talk about these common knee injuries, their diagnosis, treatment options, and prevention. My disclosures: I haven't been able to attend an athletic event. My last sports coverage was March 8th, UH against Memphis. Good win for the Cougs. Go Cougs. I have been maintaining contact with my athletic trainers and my physical therapists through telemedicine or through the phone, occasionally an in-person visit as needed. And I do miss sports. I have no other disclosures. So our common athletic injuries that we're going to cover tonight include contusion, ligamentous injuries, tendon injuries, cartilage injuries, and briefly on fractures. And I'll do this in a case-based presentation. Our sideline or on-site assessment, it can be courtside or wherever your athlete is participating. Goals include quick evaluation, address any unstable injuries, and you want to remove that athlete from field of play. Our sideline or on-court evaluations include rapid, complete, and systematic evaluations of the athlete. We want to observe for any deformity, laceration, swelling, ecchymosis, or dimpling. Palpation or feeling for any bone or soft tissue abnormality. Crepitus can clue us into a certain injury. Step-offs may indicate a bone abnormality. And an effusion also indicates more internal or significant injury. Range of motion, you want to do that to your player's tolerance, looking for an effusion, pain, or mechanical block that's preventing you from the athlete from getting or gaining full motion. Our sideline and on-site assessment can include specific tests that are listed here. Many times our patients or athletes are guarding. We're unable to do these, but also initially after an injury, don't be afraid to try some of these before some of that pain sets in. Your patients have adrenaline. It can mask some of that discomfort so you can actually get a good examination. You get to the sideline, now they're more worried, they guard, and you'll have maybe less of an assessment there. But it's important to try to get the best examination that you can. You want to do neurovascular checks, especially if you're worried about a knee dislocation. Initial treatment will include ice wrapping, knee immobilization, whether in a splint or a brace, and put your athlete on crutches. And then you have to determine whether they should stay or should they go. If you're worried about an acute fracture or neurovascular status, the patient has had a knee dislocation, they need to go immediately to a higher level of care, preferably an emergency room at a medical center, and not an urgent care, which may not be able to treat a vascular or neurological injury. You also need to make the determination, can the athlete return to participation in that event? And I would say this can be done if the patient has full strength, full motion. You test them on the sideline, his or her knee is stable, and they are able to show that dynamic stability that they need to return to their level of play. If they have no pain and no significant swelling, can pass your test, then they can return to play during that event. We're going to do a case-based discussion of these events. We'll move quickly through these. Case 1 is a 12-year-old male. He plays in the defensive position on the football field. He was running in the backfield. He got hit from behind. His medial knee impacted the turf. He was able to continue play. Said it was a little bit sore, but his coaches noticed a notable limp. On his evaluation, he has an antalgic gait, mild effusion, loss of terminal extension. His motion was 5 to 95 degrees. This is once he's in the office. And he has medial-sided knee pain. Workup included x-rays that revealed a skeletally immature patient with no fracture. An MRI was obtained secondary to swelling and lack of motion and revealed a bruise of the medial femoral condyle and a large joint effusion. There was no other abnormality. The patient had the diagnosis of a knee contusion. Treatment for this is non-surgical. It's mostly time dependent. He was using crutches until he could walk without a limp. Physical therapy focused on motion, his mechanics, and strength, which was quad and core based. Return to sport is typically between 4 and 6 weeks. Some return sooner than that, some a little after that. It all depends on restitution of strength and motion. Prevention is proper equipment use. We've all seen patients and athletes that do not wear their knee pads in the correct position, whether in football or volleyball. I've had soccer athletes not wearing shin guards sustain significant contusions and even fractures on their shins. You want to make sure the pads and protective equipment are properly fitted, and just recognize that some injuries are not preventable. Our pearls for contusion, it usually does not stop the player from initially continuing participation. It's a diagnosis of exclusion, so rule out your more significant ligament or cartilaginous injuries. Bone bruising resolves more slowly than soft tissue. You want to focus on stretching and mobility exercises. Case 2 is a 22-year-old female college basketball player who had a contact injury with another player while going for a rebound. She was hit from the lateral side, her knee buckled inward. Unable to continue play, had to be removed from competition, and her primary complaint is medial pain that's worse with pivoting. On her evaluation, minimal effusion, she's tender to palpation, just off the femur. She has grade 2 opening with valgus stress at 30 degrees, and it's painful. Her motion is relatively well preserved. She had no other instability on examination. Workup includes a normal x-ray. This, however, is depicting a patient with a chronic MCL injury, not this patient. And her MRI actually shows a disruption of the MCL completely off the distal aspect of the fibula. It's curled up here. No other concomitant injury was found on this patient on imaging. She was indicated for operative treatment based on the location. The hamstrings were underneath the MCL, which would lead towards a non-healing ligamentous injury. And based on her level of participation, she was indicated for treatment. These are her surgical images. When you first get into the medial compartment, things look good. You put a little stress, you get the drive-through sign indicating the meniscus going with the femur. The disruption is off the tibia. She was fixed with an open MCL repair. Post-surgically underwent physical therapy and returned to play at 3 months after passing return to play testing. Depending on severity of injury and concomitant injuries, return to play generally is between 3 and 6 months. Prevention, this is the only ligament within the knee that a brace is thought to reduce injury, especially in football linemen. There have been other changes in rules over the years, such as a penalty for clipping or hitting an athlete from the side of the leg to prevent this stress and injury. Pearls for MCL are isolated injuries, depending on the grade, can return to play without surgery. Grade 1s generally in 1 to 2 weeks, grade 2s 2 to 4 weeks. Isolated grade 3s can take 1 to 2 months without operative treatment. With operative treatment, it's closer to 3 months. Distal injuries are less likely to heal. There is less blood supply on the tibia, and these are often associated with other injuries. Case 3 is a 16-year-old female volleyball athlete who sustained a non-contact injury to her left knee after landing awkwardly coming down from a blocked shot. She was unable to continue play. She was guarding on her initial exam on the court, and her primary complaint was knee instability. On exam, she has a moderate effusion, a grade 2B Lockman with an endpoint. She has a positive pivot shift, which is sometimes hard to obtain in the office, secondary to guarding. Her motion was limited from 0 to 90 degrees. Workup included a normal x-ray and an MRI revealing a complete disruption of her ACL and a pivot shift bone bruise within the lateral compartment. She also had a lateral meniscus tear. Initial treatment for her was bracing and physical therapy for restoration of motion. You do not want to operate on an ACL that has limited motion. It predisposes the patient for postoperative arthrofibrosis, which we would like to minimize. After appropriate motion and strength was obtained, she underwent surgery with ACL reconstruction utilizing the autograft patella tendon. She had a lateral meniscus repair. She was in physical therapy for her post-op rehabilitation. She had return to play testing after 6 months, and every 6 or so weeks until her strength was equivocal to the contralateral side. She returned to play about 9 months. Most athletes return between 9 and 12 months post-injury. So for prevention, do braces work? They really don't. Neuromuscular training programs, they do work. So you want to do these. These can help reduce at-risk positions such as landing in the valgus internally rotated position. Studies have shown reduction in young female athletes. Our partners, physical therapists at the Memorial Hermann Ironman Sports Medicine Clinic, conduct these prevention classes prior to the start of many of our athletic seasons, and so I would look for that. This can help save injury and prevent heartache in our athletes. ACL pearls, it's a very common injury. Most at-risk non-contact athletes are soccer, basketball, and skiing. Football, it's a contact sport which puts our athletes at most risk. Females are 2 to 4 times more likely to sustain an ACL injury than their age-matched males. There is a familiar predisposition, likely secondary to tibial slope and a narrow intercondylar notch. A fusion in these are usually delayed by 24 hours. 40% have a concomitant meniscal injury. Premature return to activity, so before objective testing is done, can predispose your athlete to graft rupture, and athletes can rupture their contralateral ligament between 5 and 12%. So it's important to strengthen the other leg as well. Case 4 is a 14-year-old female athlete. She was running on the track, forgot to tie her shoelaces, tripped and fell, landing directly on the anterior aspect of her knee. She complains of vague discomfort, and she's not confident to continue running. She has no effusion. She has a mild posterior sag sign, grade 2 posterior drawer, and a positive quad active test. She is a skeletally immature patient, no fracture, was shown on x-ray. Her MRI shows a high-grade partial sprain of her posterior cruciate ligament with no associated injury. It's important to initially brace these athletes in full extension. If you're concerned about the PCL at all, this will help initiate healing and likely prevent surgical treatment for the patient. Physical therapy is focused on the extensor strengthening, no active hamstrings. Passive range of motion is started after several weeks for grade 3 injuries. We lock them in full extension for 4 weeks prior to initiation of that physical therapy. Prevention, there's really not a brace that can do this. I put here, wear your seat belt. High velocity injuries are secondary to dashboard injuries. That's the most common. So wear that seat belt, although some are not preventable. If you suspect a PCL, then brace an extension. Our pearls here, isolated injuries, low velocity occur on a knee and plantar flex foot. Grade 1 to 2 tears get 4 to 6 weeks of relative rest. Return to play will be dependent on their quad function. Isolated grade 3 tears sometimes are treated non-operatively. If it's an avulsion from the femur, it can be repaired if done so within the first 3 weeks. Case 5 is a 16-year-old male wrestler. His leg was pinned during a wrestling match. His body, unfortunately, was twisted around the knee. He felt and heard a pop. He had immediate discomfort and was unable to continue play. Of note, he had an ACL reconstruction about 18 months prior to this injury and had just completed his football season without incident. He has moderate effusion, positive Lockman. He opens with valgus stress. His dial test is equivocal, and he has normal bounding distal pulses. His workup includes x-ray, which shows no significant abnormality or fracture. His MRI shows full thickness ACL graft rupture, posterolateral corner injury, complete disruption of the medial collateral ligament from the femur, a posterior horn lateral meniscus root equivalent tear. He was in physical therapy for pre-surgical motion and limb strengthening, which is important for these knee injuries. Surgery should be done within the first 3 weeks on the collateral ligaments. This patient underwent a revision ACL with an autograft quad tendon, collateral ligament repair, posterolateral corner repair, and repair of both menisci. He is currently undergoing rehabilitation for these. Generally, return to play is close to 9 to 12 months, and return to play testing should be 85 to 90% equivocal to the contralateral side before considering return to athletic participation. Prevention is really focused on prevention of complications after this injury. You want to do on-site immobilization and bracing. You need to assess and reassess that neurovascular status. You want to do a timely reduction, and please send these ones to the emergency department, not in urgent care. Our pearls here is these ones should get your heart pumping. You need to align that limb prior to transport. Assume that there is a vascular injury. The popliteal injury can be injured in a dislocation or subluxation event. You have 8 hours prior to the limb being non-salvageable. So these are timely. 8 hours is the key. They have to be addressed prior to that. Neurovascular checks secondary to commonly involving the perineal nerve. Case 6 is an 18-year-old male baseball player who was swinging for the fences, pretty hard swing. As he followed through, felt a pop in his right leg, which was his plant leg. Immediate pain, immediate swelling, unable to continue play. He went down so hard that the coaches thought he may have got shot from the stands. He feels like his knee just gave out. He has a significant immediate effusion, global tenderness, his motion is restricted, and an equivocal Lockman. His workup included x-rays which showed no fractures or opacities within the joint. He's skeletally mature. An MRI was obtained to rule out a concomitant ligamentous injury, and it revealed a patella dislocation episode with bruising on the lateral femoral condyle, corresponding medial patella facet, and a significant effusion. There was also disruption of medial patellofemoral ligament from the patella, and as depicted here, remember these MRIs are taken with the patient laying down. He's got a lipohemarthrosis. You can see the separation of the fat and the blood with that linear line there. Treatment included a joint aspiration to help reactivate his quad. You want to control the swelling, initially in a knee range of motion brace to protect his quad with protected weight bearing. Physical therapy to begin for that extensor mechanism strengthening focused on the VMO, and eventually into a lateral buttress brace to prevent redislocation. This patient was reaspirated, had a PRP injection to augment his healing process, and the return to play really varies. It depends on how quickly you regain strength and motion. Prevention here is to prevent recurrence, as these happen in over 50% of the time. Physical therapy is the key. You want to stabilize that lower extremity, especially for cutting sports, anytime they're changing direction, rotating around that knee, or participating on uneven surfaces. Our criteria for return to play include no pain, no effusion, no apprehension, full range of motion, strength 85 to 90% of the contralateral extremity, and the ability to demonstrate dynamic stability of the knee. Pearls for patella dislocations is they can mimic an ACL tear. Physical therapy is the key. We generally only operate on these early if there's an osteochondral fracture or chondral loose bodies within the joint. And lateral buttress bracing will be used initially when they return to their sport. Case 7 is an older athlete. He's 28 years old, participating in flag football. He planted and cut to run up the field. He said he felt like his kneecap went up into his thigh. He was unable to continue play, had immediate swelling within his knee. He feels unstable, and he was told on site that he dislocated his patella. He's got a moderate effusion on exam. Motion could not be tested secondary to patient guarding. He had a palpable defect just distal to his patella, but again, examination of the ligaments is limited. X-rays included patella alta, which clues you into the diagnosis of a patella tendon rupture. There was no fracture. MRIs are obtained if you're concerned about concomitant injury, as depicted here, complete disruption from the inferior pole of a patella in a patient who had a predisposition secondary to patella tendonitis. Treatment is surgical. You want an early end-to-end repair, as depicted here in these photographs, and they go through a structured rehabilitation program. For me, they're locked in extension for 3 weeks with touchdown weight bearing. They're 3 to 6 weeks. At 3 to 6 weeks, we progress the weight bearing and the range of motion. At 6 weeks, we begin straight leg raises. Prevention for these include the use of or the modification of your risk factors, which can be modifiable. So oral steroid use, don't inject a steroid around the tendons, don't use anabolic steroids, fluoroquinolone use, limit that if you can. We don't know the time that fluoroquinolone is taken to the time that you're at risk for injury. If you can avoid them, just avoid them. And prior tendon injury or tear subjects you to new injury. It's important to do proper stretching and warm-up and avoid overuse activity. Our pearls for this condition: patella tendons tear under the age of 50, quad tendons, think of that over the age of 50. Take care of your coaches. They typically fall into this age group. Case 8 is a 17-year-old male basketball player who plays both independently in a select league and at high school. Doesn't have any specific injury or trauma. He swells if he plays. He complains of vague medial-sided knee pain. Feels like he's lost his explosiveness. He has no mechanical symptoms, but has a slight limp, which his mom says gets worse after he plays. He has a mild effusion. His motion is normal, but pain with hyperflexion. He has medial joint line tenderness. McMurray is positive for pain on the medial side, and his ligamentous exam is stable. X-rays are normal, and MRI reveals a tear of the posterior horn of his medial meniscus. Treatment included surgical fixation with an inside-out meniscal repair and placement into a knee range of motion brace. Underwent modified weight bearing for the first 4 weeks and modification of his motion. Return to play is generally between 3 and 6 months after repair. If a meniscus is debrided, return to play is closer to 4 to 6 weeks. Prevention includes proper body mechanics, lower extremity strength and conditioning programs, and proper weighted squats. Our pearls for the meniscus: you want to protect their weight bearing early after these repairs, especially for root repairs. Weight modification is sometimes up to 8 weeks. If you have a patient or athlete that is less than 10 years old and is complaining of snapping within his knee, consider a discoid meniscus. These may not be symptomatic, but it's nice to know the diagnosis. Case 9 is a 12-year-old female. She's a multi-sport athlete who complains of intermittent pain in her left knee. It's been occurring for the last 5 to 6 months. She can't recall a specific injury. She has no mechanical symptoms, but she's regularly using ice and NSAIDs, which is unusual for a 12-year-old. Her exam shows a trace effusion. She has normal motion and otherwise an unremarkable exam. X-rays include these bilateral knees, which show a skeletally immature patient with a defect of the lateral aspect of the medial femoral condyle. MRI confirms this OCD of the lateral aspect of the medial femoral condyle, shows intact articular cartilage. There is fragmentation of the underlying bone and a little bit of fluid behind that lesion. Thankfully, there's really no surrounding edema. Initial treatment is non-operative if there's no mechanical symptoms, no cystic change, no effusion. If they're having discomfort, you protect their weight bearing for at least 6 weeks. You can put them in a brace, and you slowly progress their activity if serial x-rays show healing. Operative treatment is indicated for unstable lesions and those that remain asymptomatic, and can include drilling both anterograde through cartilage and retrograde through bone, fixation of the lesion with screws, microfracture, and occasionally an osteochondral autograft transplantation if the patient's own bone and cartilage are not salvageable. Prevention of these is really unknown, as the source of this growth disturbance, we'll call it, is unknown. Is it a growth disturbance? Is it caused by trauma or ischemia? Or is it repetitive microtrauma from participation in all these sports? Generally, it's an incidental finding. Our pearls for this diagnosis, it's most common between ages 12 and 19. It involves the medial femoral condyle most often. It's most often found in males and African Americans, and 30% of cases involve bilateral knees. So get x-rays of the other knee if you find it in one. Our last case is a 13-year-old male. He's on the track at the local junior high, participates in the high jump. As he's approaching the bar on his final step, his knee gave out. He had immediate and severe pain, swelling within minutes. His examination reveals significant swelling over the patella. His motion was not tested secondary to pain. His skin is intact and his compartments are soft. The patient was placed into a brace appropriately on the field of play and sent to a local medical facility. He's skeletally immature. His x-rays revealed this displaced tibial tubercle fracture, and he was subsequently transferred to higher medical center for appropriate and urgent care. CT scan was obtained there, confirming the fracture, a patella tendon injury, and a lipohemarthrosis. He was admitted for compartment checks. Don't let these patients go home, please. Splint them and brace them in extension when they're on their field of play. Surgery is urgent. This is done by open reduction, internal fixation. This patient also had a patella tendon repair. Motion begins generally 4 weeks to allow fracture healing, and weight progression is generally at the 6-week time point. 10% of these have associated injuries, such as an ACL, patella tendon tear, as our patient did, or collateral ligament injuries. So look for those. And when you operate, avoid the proximal physis, and please monitor their compartments. Other fracture pearls, so we can see patella fractures, which are sustained from a direct blow to the knee. They're surgical if there's more than 2 millimeters of articular displacement. Tibial spine avulsions are really ACL equivalents, and those we like to fix as well if there are any displacement. In conclusion, knee injuries in sports are common. We cannot prevent all injuries, but key is proper training and conditioning, especially our neuromuscular training programs, and when in doubt, call or text your team physician. Thanks for listening.